Okay, and we're on. We're going live. Hello, everybody. Dr. Alex Earl here at Pure Plastic Surgery, and it's Hump Day with Dr. Alex Earl. So this is some of the time that I get to spend with you guys, going over plastic surgery topics, and of course answering all your questions. Once again, we are live on Instagram, TikTok, and YouTube. So we're happy to answer questions from any of those platforms, whatever is your preference there. Okay, but today is the first live in October. And so what does that mean? Well, October is Breast Cancer Awareness Month. Okay, very, very important month where we want to be aware about breast cancer, how to detect it, how to try to prevent it, and then of course after that, what are the treatments, and then importantly for plastic surgery, what are your reconstructive options? Okay, so we call it Pinktoberfest. You're going to be seeing a lot of pink here at Pure, and we also have a couple kind of promotions because of the Breast Cancer Awareness Month. So what are those? Well, any breast procedure that is booked during the month of October will have $500 off. So that's how we can give back to the community. And then for every breast procedure that we do here at Pure, we're going to be donating $100 to our favorite breast cancer charity. Okay, so giving back to the charities in the community here for Breast Cancer Awareness Month. Okay, so today, a lot of our videos and things, throughout the month are going to be related to breast cancer. And so today we're going to talk about, kind of what it is, how common is it, and then towards the end, we're going to talk a little bit about what are some of the reconstructive options once you've been treated for your breast cancer, which is, very, very, very important as well. Okay, so breast cancer is actually fairly common. So in a woman's lifetime, we can expect about 1 out of 8 women will have breast cancer. Okay, so 1 out of 8 lifetime possibility of getting breast cancer. Of course, there are multiple different types of cancers, and some more aggressive than others, and that's kind of beyond the scope of what we can go over here. But depending on the type of breast cancer, depending on how aggressive it is, depending on whether it's localized or it's spread everywhere else, that's how all your treatments are going to depend on, and also what your survival rate is going to depend on as well. Okay, so it's estimated that in 2022, so this year, it's estimated that approximately 287,000 women here in the U.S. Will be diagnosed with breast cancer, which is quite a bit. It's quite a lot. And what we found, throughout the years is that the incidence is kind of about 1 out of every 8 women. That incidence has been fairly stable. It hasn't really gone up, it hasn't really gone down. So there's not a lot that we've been able to do in terms of getting breast cancer, but there is a lot that we've been able to do in terms of treating breast cancer, and then of course treating the deformity after breast cancer with reconstruction. Okay, so it is about 15% of all cancers, and when you look at a table of all the different types of cancer, it's number 1. It's pretty much the most common cancer out there. Okay, so that's why this Breast Cancer Awareness Month is so important. The death toll for 2022 will be estimated at about 43,000. Okay, so still fairly high. And most of these are for patients that present with advanced disease, meaning that it's not just a small nodule in the breast, but it's spread to the lymph nodes, it's spread to the liver, it's spread to other areas of the body. Okay, it affects all women. All women are affected, and a small percentage of men. There's about a 10% breast cancer in men as well, but it definitely affects all races. It affects all women just about equally. Okay, the peak ages are between 55 and 74. That's the kind of the highest peak of incidence of breast cancer at that time. It's fairly rare under the age of 35. So fairly rare under the age of 35, unless you have some sort of genetic disposition or a very, very strong, family component to that. Okay, so that is why the self breast exam is typically not recommended. You don't really have to start that till age of 40. If you want to start at 35, even better. But definitely at 40, you have to start doing this self breast exam, which is going to be a monthly exam. You typically do, in the shower, and you want to do that because you can be the first one to detect the breast cancer, and you detect it early then the survival rates are really, really good. But if you don't detect it early and it's spread, then unfortunately it becomes a lot more difficult to treat. You're going to require a lot more chemotherapy, a lot more radiation, a lot more surgery, and the mortality rate is going to be higher. So that's what Breast Cancer Awareness Month is all about. It's about, of course, educating everyone about breast cancer, but importantly, educating everyone about early detection and self-examination. Super, super important. Also, starting at age 40, that's when we start doing our yearly mammograms, okay? So at age 40, you want to start doing your yearly mammogram. If for whatever reason you have more of a dense breast tissue, then you can also do an ultrasound, which will help detect an early breast cancer as well, okay? So starting at 40, self-breast examination, yearly mammogram, plus minus ultrasound depending on how dense your breast tissue is. All right, and that way you can potentially detect the cancers when they're very, very small, about 1 centimeter or so. And when they're small and localized, it's much, much easier to treat with a very, very high survival rate. Okay, because the overall 5-year survival rate is 90.6%, which is really, really good. That's a very good survival rate. Most other cancers will have a much lower 5-year survival rate than that. Okay. And that is separated by where the disease is located at the time of detection. So if you detect the disease and it's localized, meaning that it's a small kind of little tumor in the breast and has not gone anywhere, absolutely anywhere else, then the 5-year survival rate is terrific. It's 99%, which is why self-examination is so important. Because if you catch this early, you're going to survive. It's like 99%, okay? Now, once it is regional, meaning that it's moved to the lymph nodes that you find in your armpit area, now the survival rates come down a bit to 86%. So not bad, still fairly good, but of course it has come down to 86%. And here's the kicker. If it was not detected and it spreads and it's now in the lung or in the liver or somewhere else that's not the breast or the local lymph nodes, then it's a really, really aggressive. It's spread quite a bit and the survival rate has plummeted down to 30%. Okay, so one of the main reasons why the total 5-year survival rate is so good is because of breast cancer awareness, because of all these things that we're talking about, we're catching a lot more of these cancers in that localized phase where we have very, very good treatment options and a very, very high survival rate. And so that's the whole point, because like I said before, the incidence is not going to change. Pretty much 1 out of 8 women are going to get breast cancer. And this has been the same since we started gathering data, at least since like the 1970s. So that's not going to change, okay? But what can change is detecting it early, and then of course, getting on top of the treatments early and doing the adequate treatments to then increase that survival rate. All right. So what are the potential treatments? I didn't go into it here because again, it's a very, very broad topic, and perhaps we can do lives kind of more specific to that. But the treatments are basically divided into 3 categories. 1 is chemotherapy, 2 is radiation, and 3 is surgery. Okay. And where we become involved as plastic and reconstructive surgeons is, of course, with the surgical aspect of it. So again, what type of surgery? That again, it depends on where, how quickly you find a tumor, the size of the tumor, and things of that nature. So if you find a very, very small, kind of 1 centimeter tumor, typically they just do what's called a lumpectomy. A lumpectomy means you're essentially just removing the tumor with a margin of normal tissue around it. And a lot of times when you do a lumpectomy, there's no need for reconstruction. Okay. Now, if it's a large tumor, especially relative to the size of the breast, then sometimes you have to do what's called a mastectomy. But again, if you catch it early, there's different types of mastectomy. There's like the total mastectomy, where they're removing a whole bunch of skin and entire breast tissue, and you're left completely flat with a scar that goes across the chest. Okay. And then there's what we call skin sparing mastectomy. That's when you preserve pretty much the entire skin envelope. And you just remove the breast tissue. And then if you take it a step further, you can have what's called a nipple sparing and skin sparing mastectomy, which means you're you're sparing all the skin and your own nipple. And that, if you can do that, and for that, of course, you have to catch the tumor fairly early. If you can do that, once we come in for the reconstruction, you can have a breast like almost looks like just like an augmented breast, like nothing was ever done. That's like kind of the best of all worlds if we can do that. Okay. All right. So those are the types of the different surgeries, and then of course, if you find breast cancer in the lymph nodes, then the lymph nodes have to be removed as well. Okay. And then depending on what you have there, then almost everyone's going to go through some sort of chemotherapy. And again, there's a range there. It can be from anywhere from hormonal therapy called tamoxifen or something similar to like a full-on, like real, like hardcore chemotherapy. Again, depending on the stage of the tumor. Okay. And then the other thing we got to consider is radiation. So typically, if you have breast cancer in the lymph nodes, whether it's a sentinel, like one lymph node or all of them, you're going to need some sort of radiation on top of that. Typically, if you're doing a lumpectomy, a lot of times that has to be followed up with radiation as well. Okay, so those are the different types of treatment options. But where do plastic surgeons come in? So why are we so involved with Pinktober and breast cancer awareness? Because a lot of what we do in terms of reconstruction is breast cancer, breast reconstruction. And as many of you may know, I was at Cleveland Clinic here in Florida before opening Pure. I was a staff member at Cleveland Clinic, Florida for 5 years. And the bulk of what I did there was breast cancer reconstruction. I did all sorts of reconstruction, okay? Because there's many different ways that you can reconstruct the breast, depending on how much tissue we have to work with, okay? So what are the different options there? Well, it falls into like two main categories, okay? The two main categories are you're gonna have what's called autologous reconstruction and implant-based reconstruction. So for autologous reconstruction, we're basically using your body's own tissues to reconstruct the breast, okay? And so there's no implant involved when we're doing autologous reconstruction, okay? And when you do autologous reconstruction, there's a couple of options there. You can do the surgery, they're called flaps, but you can do what's called the regional flap versus a free flap, okay? When you do a regional flap, that means you're taking tissue from the body and it never kind of leaves the body. It's always attached. And the most common regional flap that we do is called the latissimus flap, where we take tissue and skin from the back, and then we kind of we tunnel it underneath the armpit and bring it towards the front to recreate a breast. So that's the most common flap there. It's called a latissimus flap. But we also do what's called free flaps. Free flaps, or you can think of them like autologous transplants. Like you're taking a piece of tissue, you're completely separating it from the body, but you're keeping it attached to it like a little artery and vein, and then you're putting it in a separate area, and then you're reattaching the artery and vein with the use of a microscope. But these are little tiny, like 1 to 2 millimeter vessels, okay? And one of the most common free flaps that we do for breast reconstruction is called the DIEP flap. So DIEP, okay? A deep flap. And what that does is that it takes tissue from the belly area, okay? And then we take the skin and the fat, very little to no muscle, and we keep that attached to an artery and vein. We then detach the artery and vein down in the groin area, and then we transport that to the chest and connect it to an artery and vein that you have here in the chest area, okay, the mammary vessels. And it's a beautiful surgery. You're basically combining a tummy tuck with breast reconstruction, so you get the advantages of the tummy tuck portion of it. You get the advantages of an autologous reconstruction using your own tissues with no implants, and it can be a very beautiful surgery. And I did plenty of these when I was at Cleveland Clinic. It is a highly technical surgery though. Not easy to perform. It requires the use of a microscope. And typically, if you're doing it on your own, it can take anywhere from about 10 hours. However, at Cleveland Clinic, me and my partner there, we did what was called a 2-team approach, and we could do basically a bilateral deep flap, meaning reconstructing both breasts in about 6 to 6.5 hours, which is truly excellent as well. Okay, so that's your autologous reconstruction. And then you have your implant-based reconstruction. So implant-based reconstruction means that you're using an implant to reconstruct the breast. And you can do that with or without biologic mesh. So there's a common one one of them is called Stratus, which is basically made from the dermis or the skin of a pig, where all the cells are removed, but you keep that matrix there. And then there's one actually that uses human skin, cadaveric skin, to do that as well. That one's called Alloderm, which is really, really good as well. Okay, and the cool thing about implant reconstruction is that actually either one, you can do either staged, meaning that you do your mastectomy, you go through all your treatments. Once everything's done and you're doing well, you come back for your reconstruction. Or sometimes you can do these immediate, meaning that you're following the breast surgeon and you're doing the reconstruction right after they finish their mastectomy. And that's why I mentioned that nipple sparing mastectomy. So a lot of times if you're able to do that nipple sparing mastectomy, we can do an immediate breast implant reconstruction. We'll place the implant underneath the muscle. We'll use some of that biologic mesh. We'll put the implant underneath there and create a beautiful breast, almost like if you had a breast augmentation at that time. Okay, so those are all the different options there. Now, if you're doing a staged implant reconstruction, a lot of times then you require a few stages in terms of your surgery. You first have to put in what's called a tissue expander, because that skin, we need to expand that skin to create enough room for your implant. So you put in a tissue expander, then you have to expand that skin slowly over a few weeks. Once it's fully expanded, you let it just sit there for a couple months. And then you bring the patient back to remove that tissue expander, because that's a temporary device, and you exchange that tissue expander for your permanent implant. So it requires at least 2 surgeries, sometimes 3, because you got to go back and do some touch-ups and fat grafting and stuff like that. Okay? All right. So I think that's a pretty good explanation there. But I'll be happy to answer any questions related to breast cancer, breast reconstruction, or any other plastic surgery topic.
Okay, let's start with the questions.
Yeah, let's do it.
Okay, Doug, where do you study medicine? Whose school med you went?
Yeah, so I went to NYU, so New York University School of Medicine, and I was there from 1998 to 2002.
Okay, we can request to have a certain size of areola after a lift?
To a certain extent, yes. So we do use this, we call it a cookie cutter. It's actually, the technical term is a nipple sizer or areola sizer. And it has, different sizes there. So if you want something a little bit smaller, we can do that. If you want something a little bit bigger, we can do that. I mean, requesting a very, very specific size, it'll be tough to guarantee that. But yeah, we can definitely tailor it to what you would like.
Okay. How long, this is not about breast, but how long does it take to see etching results after surgery?
Yeah, so it's going to take at least 4 months, I would say. Better at 6 months. But you're definitely not going to you're not really going to be seeing it much more before then. So when when you do the ab etching, it can look really, really great on the table. But by the time you're seeing it, a whole bunch of inflammation has settled in. You got fluid and all this stuff going on, bruising and everything else, and you're not really going to be able to see it very well. And so you got to wait for all that swelling, all that edema, all that bruising, all that inflammation to calm down. And it's a slow, gradual process. So it's going to take at least 3 to 4 months before you can even really start to see the result of the ab etching. So don't get discouraged, okay?
They're here. Is the 23andMe gen testing accurate for detecting breast cancer genetics?
So I don't know about those, how accurate those are. I know 23andMe is good. You're just looking at your DNA to see your ancestral patterns and stuff like that. I'm not sure how well they do for when you're testing for those genes. For that, I'll probably go with whatever your provider is using, right? So I'll go to your doctor. You can go to your gynecologist or your primary doctor, and they can do some genetic testing. But the genes that we're talking about, and that's a good question, are what they call the BRCA genes, BRCA, and there's a BRCA1 and a BRCA2. Okay, and those are the ones that you want to be looking for, because if you have those genes, then the incidence of breast cancer is much higher. Not only is it much higher, but they tend to occur sooner. And so therefore, a lot of times you want to be testing and doing things before the age of 35 as opposed to just the general population.
Okay, do you have to have the recommend BMI for any surgery, such as, for example, as arm lipo
Yes, so
or arm lift?
yeah, so arm lipo, honestly, we have our top BMI is 30 for pretty much any procedure, okay? So the top of the BMI is going to be 30. Now there are certain procedures where there's a bottom BMI, not for all, but for example, BBL, you don't want to have a BMI under 20 because then you're not going to have enough fat for that procedure. So, but in terms of what is our max BMI, for me here at Pure, the max BMI is 30 for all procedures.
Okay, this says, hey doctor, which areas can you lipo on a MMO, on a mommy makeover?
Right, so the most common areas that we lipo with the mommy makeover is your flanks and waist area. So pretty much all along the side here, okay? And that's what's typically included with a mommy makeover. So can we add a few other small areas? Depending on the patient, we can. Remember that we are limited as to how much fat we can remove here in Florida at the time of the mommy makeover. So the maximum amount of fat that we can remove is 1 liter. But if you want to add a small area, like say for example, lipo to the chin, that's typically doable. You don't get a lot of fat there. It does create a nice change, a beautiful contour, but it's not like a high volume area. So a lot of times we can add that to the mommy makeover as well.
Okay, Doug, how low do you do the tummy tuck line?
So I try to keep it as low as possible, but several studies have shown that you don't want to make it too high, obviously, but you also don't want to make it too low. If you make it too low, you can disrupt what we call some of the lymphatic system in the suprapubic area, and then that tends to swell up and then never go down. It just stays very big and bulky and swollen. So what is a good rule of thumb? This is what I always go for. I always try to put it about 7 centimeters above the vaginal commissure, okay? So the top of the vagina there, you want to measure 7 centimeters from there. That's the lowest point. From there, then you want to do a nice gentle curve, okay, so that it's easy to hide in a swimsuit or in the underwear.
Okay, this one. Is BMI 21 too little for a BBL?
So it's on the lower end, but it's acceptable. So 21 is good. So for BBL, we're doing between 20 and 30 BMI. Okay, so between 20 and 30 for a BBL. So at 21 you'll be okay. It also depends on what your expectations are, right? If you're wanting like this very, very, huge change with a lot of volume, obviously you're not going to have that. It'd be pretty rare that with a BMI of 21 that I'll be able to get, the max here, which is 4 liters. It's probably going to be something like half of that, perhaps 2 liters. And then of course I can divide that in 2 and put 1,000 cc's into either side, create a very, very beautiful shape.
Okay, another question. Doug, is obligated to have drainage or not after a BBL?
So it's not obligated, so it's not mandatory. I like to use the drain. I think it also makes life a little bit easier for the patients. Not so much the first night, because you're still going to drain a lot the first night from all the little sites. But after that, it all just kind of goes into the drain tube, and it's a lot more manageable. And I think it helps also the massage therapist, because the drain is not just where it comes out of the skin. The drain actually snakes across the entire lower belly. And so when they do their massage, they can massage all that fluid down to the drain from both sides, and then from there it'll go into the tube and outside the body, which is what we want. So I do think it helps the massage therapists as well, and those are a few reasons why I like it. Having said that, it's not absolutely mandatory. This is different from, say, a tummy tuck where it is absolutely mandatory for me. So with the BBL, if you tell me, doc, I absolutely do not want this drain, then that's fine. Then we won't put the drain in. We'll leave the little sites open because we still need that fluid to come out when they do your massages. And it's just going to be a bit more messy for you overall, but it can be done.
Okay, are there alternatives to general anesthesia?
There are, if you're talking just in general, like, in other practices, yes. There are surgeons out there that'll do liposuction and BBL with sedation and plus local anesthetic. Now, if you're talking about here at Pure specifically, no, right? We do all our big lipo cases, all our lipo 360, all our BBLs are done under general anesthesia. Okay.
Okay, do you lipo the upper back with lipo 360 or it's a separate area?
So we lipo most of the back, pretty much. I don't know, almost 90% of the back comes included because we go from above that bra line from here all the way down, which includes all this area here. I know a lot of women don't like this area here, kind of lateral breast just beneath the armpit. That's all included as well. What's not included is what we call the buffalo hump. Buffalo hump up here. Okay, so we have a big kind of bulge there, a bit of excess fat, then that is considered an additional area, which we call the upper back. Because it's the upper back.
I like this because I don't know the answer of this one is what
Okay.
exactly is coming out in the drains? Blood, bodily fluids, water,
Yeah.
fat?
All of the above. So what comes out of the drain? So most of it's going to be what we call serous fluid, which remember. So the first step to any liposuction procedure is that we instill a bunch of fluid into the tissues, what we call tumescent fluid, okay? And that's why you're draining so much, especially in those first 24 hours. So a lot of that fluid is coming out into the drain. There's gonna be some degree of blood. And then with liposuction or even with the tummy tuck, there's gonna be fat particles in there that have been dislodged, that are loose. And so sometimes you can get, little fat particles coming out into the drain. And that's okay too. Sometimes you get clots coming out into the drain as well. What's funny is that a lot of times when these little clots or these little fat particles come out, they look like little stringy worms. And we've had plenty of patients calling us freaking out in the middle of the night saying that they have worms in their drain. Believe me, there's zero chance you're gonna have a worm inside your drain, okay? But this tissue that comes out, this kind of fatty tissue, sometimes these clots, they're gonna look kind of stringy like that because they're going through this thin tube. And so then when you push them the other side, they look like this little worm type thing, but it's not a worm, believe me. You don't have worms inside your body, inside your drain, okay?
Okay, this is a long question. If someone had a round one and once a round two,
Yeah.
but hips did not stay the first round,
Yeah.
what are the chances they will stay the second round? Is it possible that if you don't have hips, that round two will?
So yes, the chances are better than the first round. So it's very common to come back to add more to the hips, and I think that's a very reasonable thing to do. Remember, you're adding onto a foundation, and a lot of people will say, I lost all my hips. To be honest, it's actually extremely rare that you would lose all the hips, that you would lose 100%. That doesn't come. So what is common is to lose 50%. So what happens is that you come out of surgery, you have like these beautiful rounded hips, and then you lose 50% of that, and so then you feel like you lost it all, but you didn't lose it all. So you kept some. And so then you've created now a different foundation for the next stage. All right, and so now you can continue to build on that. So say you place another, whatever hundreds of cc's of fat, maybe you'll lose 50% of that, but now you're building. It's kind of like Legos. So you build the foundation, and then you can build on top of that. So I think it's perfectly reasonable and a good idea to go back for a second round if you want to add more to your hips.
Okay. This is about breast. Let's go in with this one. It says,
All right.
if I travel to Miami for a breast leave, how long should I plan to stay in the area before traveling back home?
Yeah, so for most of the surgeries that we do, especially all of those that are under general anesthesia, which is most of our surgeries, then you want to stay here for a minimum of 5 days post-op. Okay, so there's been, there's actually a recommendation, what they call the white paper by the American Society of Plastic Surgeons. Of course, I'm a member, and they recommend that no one should be flying home. No one should be on a flight basically within 5 days of general surgery. So you need to be here a minimum of 5 days post-op. Okay, and so the day after surgery is post-op day 1.
Okay, and the last one is this. Do you only use the ultrasound for BBLs or it can be used in other surgery?
So it has multiple uses, but really the main use that I have for it here is for the BBL. That's kind of the most critical use that we have for it, right? Because we want to make sure that we're in that safe space between the muscle and the skin, and that we're not, we're not in any what we call danger zones. Okay, so that's really what I use it for the most. I mean, can I use it for other things? Like sometimes, say for example, someone, we're not sure whether a patient has a seroma or not after a liposuction. Well, I can use the ultrasound to take a look and determine if it is a seroma or if it's not. If it's not seroma, then it's just swelling and we don't do anything. And if it is a seroma, sometimes we put a needle in it and aspirate. So there's multiple uses for the ultrasound. But yeah, for me here at Pure, the number one use is for the fat transfer portion of your BBL. All right, everybody. Well, I hope this was, you got some good information here. Like we said, we're going to be spending a lot of time in October talking about breast cancer, breast procedures, breast reconstruction, and everything related to that. But of course, we're always happy to answer any of your plastic surgery questions throughout the month, okay? And then remember our Pinktoberfest promos. So anyone who books a breast procedure during the month of October gets $500 off that procedure. And of course, for all patients undergoing breast surgery during the month of October, we're going to be donating $100 to our breast cancer charity of choice. Okay? All right, everyone. Well, I look forward to seeing you all next week on Hump Day with Dr. Alex Earl. Take care, everyone. Ciao.